My name is Randy White, and I'll be demonstrating the pressure dressing. Okay, the first thing is, of course, is BSI to make sure that you have your gloves on. The next thing is you'll need some 4x4s, and as soon as you get there, you want to make sure that you cover that and put direct pressure, pinpoint pressure over that bleeding. Okay, once you've done that, you may need to move on to a different skill, like for instance airway or treating for shock or something like that. So I'm going to put a pressure dressing on it. Okay, now remember, once you put this on here, you shouldn't be looking at it anymore. I'm going to put an anchor wrap on, and an anchor wrap really is just to keep my bandage from slipping all over the place. And now I'm going to, again, keeping direct pressure over the top, I'm going to be moving the wrap distal to proximal, proximal to distal. Okay? And as I'm going to make this look a little pretty, okay? Now when I want to do direct pressure over the site, okay, I'm going to bring the bandage around, and now I'm going to move the bandage over and put direct pressure over the site with that. I'm going to come around, being careful now not to drop my roller gauze, because if I do, then I've lost the ball game. And it's a lot easier to drop when you're rolling backwards. Now I'm rolling forwards again. I'm going to do this one more time. Here, and one more time here. Okay? Now I'm just going to finish it up, making sure that I put plenty of my roller gauze over the top, again tightening up as I go, making sure that the bottom side is loose so that I get good pulses. Now I'll tape and tie and tuck. I want to make sure that I have a good pulse here. I want to make sure I got good capillary refill here.
Using an open triangular bandage, place the apex of the bandage about 2 inches below the base. Fold in half horizontally to make a broad bandage. Fold in half again horizontally to make a narrow bandage. Place both ends of the bandage to meet in the middle. Fold in each side to the center. Fold in the center to make a pressure pad. Using a narrow bandage, make 2 loops with each end facing opposite directions. Place hand through both loops and secure around the wrist. Each loose end is tied around the patient's neck using a reef knot. In the case of an arm fracture, keep the arm completely immobilized by tying 2 narrow slings around the injured arm above and below the fracture site and tie under the uninjured arm. Using a narrow bandage, hold one end in your hand and wrap the bandage around spread fingers. Wrap the tail end of the bandage around the donut to hold it together. For musculoskeletal injuries, such as sprains, an elastic roller bandage can be used to apply firm and even pressure for support and to minimize swelling. When applying a roller bandage, always be sure that the pressure is even and firm. Ensure that the circulation of blood is not slowed to the fingers or toes of the affected limb. This can be checked by squeezing the tip of the toe or finger and looking for the return of colour to the part. Place the injured arm across the chest with the hand towards the shoulder of the opposite side. Place a triangular bandage over the injured arm with the apex towards the elbow of the injured limb. Tuck the bandage from below the arm under the injured limb. Take the inside edge of the bandage and twist with the outside edge at the elbow. Pull the bandage around from one elbow to the shoulder of the uninjured limb to meet with the other point. Tie a reef knot just below the collarbone and tuck the loose end in. Hold one end of the bandage in each hand. Place the right end over the left end and loop it under so it is now on the left side. Take the new left side end and place it over the right side end and loop it under. Pull each end tightly across to make a reef knot. The flat side of the knot should be facing down for comfort. To untie the knot, take the left end and pull it across to the right. This will loosen the knot, making it easier to remove. Place pressure pad onto the wound. If possible, ask the patient or assistant to hold the pad in place. Using an open triangular bandage, place the middle of the bottom edge just above the eyebrows, ensuring that pressure is constantly maintained on the wound. Bring the two ends of the bandage over the ears and to the back of the head. Tie the ends together and pull to tighten it at the base of the skull. Bring the ends to the front and tie a reef knot on the forehead. Tuck the ends into the bandage on the sides. Place one hand on top of the head and by pulling on the excess material under the knot at the back of the neck, the head bandage will tighten and pressure will be maintained on the wound. Using a magazine or a stick as a splint, tie one narrow bandage below and one above the fracture site. Use an open triangular bandage placed under the injured arm and across the body. The apex of the triangular bandage should point to the side of the injury, and one end should sit over the shoulder of the uninjured side. Tuck the apex in behind the elbow and take the loose end to the shoulder of the injured limb and around the neck to meet the other end. Tie the ends together in a reef knot just below the collarbone. Check circulation in the arm by squeezing the tip of the thumb, looking for the return of colour to the part. A neck brace can be easily made by folding a magazine and wrapping it up in a triangular bandage. The height of the brace should be 12 to 15 centimeters. Rub the wrapped magazine around your knee to give it more flexibility.
На выступающие части лица, нос и подбородок накладывают так называемую прыщевидную повязку. Верхняя завязка фиксируется на темени, а нижняя на границе шеи и затылочной области. Крестообразная повязка на затылок выполняется для фиксации перевязочного материала на ранах в затылочной области и в области задней поверхности шеи. Повязка состоит из одного циркулярного тура вокруг лба и затылка и двух косых туров, пересекающихся на затылке крест-накрест. Один косой ход идет снизу вверх, другой сверху вниз. Последний тур – krugowy, закрепляющий.
Możemy bandażować głowę na dwa bandaże. Jest to bardziej taki prosty sposób. Korzystamy z dwóch bandaży. I tak, jeden bandaż. Zaczynamy bandażowanie od czoła. Jeden bandaż przesuwamy tak do tyłu. Drugi bandaż proszę mi przytrzymać. Mam asystentkę. Tak, proszę przytrzymać. Tak. Drugi bandaż wykorzystujemy i właśnie dobrze, oplatamy całą głowę. Tak jest. Tym sposobem, właśnie, tutaj można pod odpowiednim kątem bandażować. I teraz lecimy sobie pyk do tyłu i tym bandażem drugim, tak, bandażujemy. I po czym znowu z tej strony, z tym, że tutaj już musimy też troszeczkę zadbać o to, żeby to było bardzo estetycznie. Tym bandażem pod odpowiednim kątem, do tyłu głowy przechodzimy. Proszę bardzo. I lecimy do przodu. Proszę, w ten sposób. Tak. I tu uciskamy. Jest to o wiele bardziej prosty sposób bandażowania głowy i można pod różnymi kątami, także cała głowa będzie nam bardzo ładnie zbandażowana. O, i tak zwane właśnie działanie na 2 bandaże. I wtedy raz w lewą stronę, żeby to właśnie bardzo ładnie tutaj całą głowę pokryć, raz w prawą i 2 bandaże na 2 ręce pracujemy. I później, o właśnie, i tutaj, o, tak, i tym bandażykiem wokół. I tak jak mówię, tutaj trzeba dbać o to, żeby to tak estetycznie wyglądało nad czołem. O, i żeby oczywiście pacjent coś widział. Widzimy coś?
Wszystko.
Widzimy wszystko. Świetnie. No. I uciskamy dalej. I lecimy już do tyłu i tutaj możemy sobie... O, proszę bardzo. I możemy sobie zakończyć. Także wykorzystujemy 2 bandaże i mamy ślicznie zabandażowaną główkę i proszę bardzo, wygląda to bardzo estetycznie i pacjent już jest bezpieczny. Bierzemy sobie teraz, żeby to było tak w miarę też estetycznie, na boczku. Możemy podwinąć troszeczkę i żeby było i wygodnie na boczku. Myślę, że nie będzie kuło w ucho. I kończymy. Możemy, żeby było lepiej, wygodniej, możemy nawet 2 zapineczki. Tak, jeżeli rana dotyczy miejsca gdzieś tutaj, no oczywiście my tutaj akurat zbandażowaliśmy tak, że łącznie z łukami brwiowymi, ale można nieco wyżej. Także i w ten sposób właśnie zabandażowana jest, zabezpieczona po urazie głowa pacjenta.
The following has been made possible with a grant from the Lincoln Financial Foundation.
Intramuscular deltoid injection. Cleanse the area with an antimicrobial swab. Use a firm, circular action moving outward from the center. Let the area dry. Remove the needle cap by pulling it straight up. Hold the syringe in your dominant hand between thumb and forefinger. Hold the skin taut with your non-dominant hand. Dart the needle into the tissue quickly. Once needle is in place, use thumb and forefinger of the non-dominant hand to keep the lower end of the syringe steady. Slide your dominant hand to the end of the plunger. Inject medication slowly. Once medication has been injected, wait 10 seconds before withdrawing. Angle of intramuscular insertion should be between 72 and 90 degrees. Withdraw the needle smoothly at the same angle of insertion. Apply dry gauze with gentle pressure. Do not massage the site. Do not recap the used needle. Engage the safety shield or needle guard. Discard needle and syringe into appropriate receptacle. Remove gloves. Assess patient's response to medication.
Divergent spica for the elbow. At first, 1 or 2 turns are placed over the point of the flexed elbow. The succeeding turns are taken alternately above and below the elbow, crossing in front of the joint. The arm must be supported in a sling.
Before putting eye drops in, clean your hands. Always be careful not to touch the dropper on the eye or surrounding skin to avoid hurting the eye or contaminating the drops, and don't worry if the occasional drop is missed. For older children, get your child to sit in a comfortable chair with the head tilted backwards, chin upwards towards the ceiling. Ask them to open their eyes and look up towards their eyebrows. Gently pull out the lower lid and put the drop into the pocket between the lower lid and the eye. If this is difficult, you can also ask them to close their eyes gently and place the drop on the skin in the corner of the eyelids. Your child can then open their eye, or you can gently open their lids using your index finger and thumb, and the drops will roll into the eye. This is best done with your child lying flat. Wherever you can, older children needing long-term drops should be encouraged to learn to put their own drops in. With clean hands, they should hold the bottle of drops in one hand. With the other hand, they should pull down the lower lid gently whilst looking back up towards the brows and leaning their head right back to look up at the ceiling. They can rest one hand on the other to steady them and squeeze the drop into the eye. It may take a little practice to get it in just the right spot. Babies and young children often don't understand why they need drops and can wriggle and close their eyes. Often you will need to use some techniques to keep them still. As long as this is done quickly, you will get the drops in safely with as little upset as possible. Ideally, get another adult to help. Get your child to lay down or lie back in someone's arms if very young. Sometimes swaddling them in a blanket can help keep the arms and legs out of the way. Allow your child to close their eyes and you can then use one of two techniques. Firstly, you can open the upper and lower lids gently using thumb and index finger and put a drop into the eye. If this is difficult, if you can get them lying flat, put a couple of drops on the skin by the inside corner of the eye, then, depending on age, either ask them to blink several times to allow the drops to run into the eye, or gently part the lids to allow the drops to flow in. If you're alone, there are ways to allow you to instill the drops. Sit on the floor with legs straight out in front of you and slightly apart. Lay your child between your legs so that their head is kept still between your thighs and their arms are tucked under your knees. This allows you 2 free hands to get the drops in quickly and there is no chance of your child hurting themselves. For any age, you can do punctal occlusion to avoid too much of the medication going down the nose and reduce the chance of any side effects. Immediately after instilling the drops, place your index finger firmly over the inner corner of the lids for 5 to 10 seconds. Using these techniques, you should be able to get drops into your child's eye, no matter what their age, safely and quickly.
Bandage for the finger. Take a bandage 1 inch wide. Take 2 turns round the wrist in order to fix the bandage. It is then brought over the back of the hand to the finger to be bandaged. Take the bandage to the tip of the finger by 1 or 2 oblique turns and bring it back to the root of the finger by several spiral turns. Allow the bandage to cross the former turn on the back of the hand and reach the wrist. Here it finishes off after surrounding the wrist. Take turns with 1-inch bandage round the leg just above the ankle. Now make a turn round the foot, passing over the dorsum and across the sole to reach the inner side just above the ball of the great toe. Then, passing over the dorsum, reach the outer aspect of the great toe as close to the tip as possible. Take few spiral turns towards the base and continue over the dorsum, outer border of the foot and across the sole to the inner side of the foot. Finally, to finish the bandaging, take turns round the leg. A figure of 8 bandage is advisable. Take a bandage 2-inch wide and fix it by a couple of turns round the wrist from within outwards. It is then carried across the back of the hand to the base of the little finger, whence it crosses the palm to reach the first webbed space. And then it is continued over the dorsum to the wrist, thus forming a loop round the hand. The turns are repeated alternately round the wrist and the hand.
Мы накладываем шапочку Гиппократа второго типа при помощи одного бинта. Мы сажаем пострадавшего к себе лицом, отворачиваем бинт примерно на 15 см, чтобы удобнее было начинать работу. Прикладываем его к лобной части головы пострадавшего и делаем 2 закрепляющих тура вокруг головы. Затем в лобной части головы мы делаем перегиб и ведем его к затылку. Там мы делаем еще один перегиб и ведем его снова к лобной части головы. И закрепляем наши перегибы одним туром вокруг головы. И повторяем эти действия до тех пор, пока не закроем теменную часть головы. При этом сзади наш перегиб мы фиксируем рукой. Делаем последний закрепляющий тур вокруг головы. Затем закрепляем бинт. Все, мы наложили шапочку Гиппократа второго типа одним бинтом.
При этом уши оставили открытыми.
How to bandage a hand. We use our hands for almost everything we do, so having an injured appendage is, well, less than handy. Dress it now and you'll be able to handle most anything that comes your way. You will need a 2 to 3 inch wide bandage, binding clips or adhesive tape. Optional, gauze. Step 1. If the hand is bleeding, clean and dress the wound before bandaging it. If the hand will be bandaged a long time, place rolled up gauze between the fingers to keep moisture from gathering between them. Step 2. With the victim's hand palm up in front of you, place the end of the bandage on the inside of the wrist and wrap it around the wrist twice. Step 3. Turn the victim's hand palm down and bring the bandage diagonally across the back of the hand so its upper edge passes just below the pinky nail. Step 4. Bring the bandage across the ring, middle, and index fingers, making sure to leave the fingertips exposed. Step 5. Bring the bandage diagonally across the palm of the hand toward the outside of the wrist, completing a figure 8 around the hand. Step 6. Repeat this figure 8 a few times, staggering the position of the bandage so it doesn't bunch up on each pass. Step 7. Use the binding clips found in the bandage packaging or apply a strip of adhesive tape to keep the bandage in place. Step 8. To make sure you haven't impaired the victim's circulation, squeeze the tip of a finger on the bandaged hand and gauge how long it takes for its color to return. If it takes longer than 3 seconds, undo the bandage and redo it with a little more slack. Did you know? Including the wrist, there are 27 bones in the hand. How to bandage an elbow. Bandaging an injured elbow is simply logical. If you physically compress the area, it won't be able to swell as it might if left to its own devices. It's also a pretty simple process. You will need a 2 to 3 inch wide bandage, binding clips or adhesive tape. Optional, soap and water, dressing. Step 1. Place the tail end of the bandage on the inside of the arm, just below the elbow, and wrap it around the arm twice to secure the bandage. You want it tight enough to apply pressure, but not to cut off circulation. Have the victim bend the elbow slightly if they can do so without causing further pain or injury. This positioning will make the bandaging easier. Step 2. Wrap upward, winding the bandage diagonally from the elbow toward the bicep. Step 3. When you reach the elbow, wrap a figure 8 pattern around the elbow so the X, or the middle, of the figure 8 is on the inside of your elbow, then continue upward. Step 4. When you reach the bicep, finish the bandage by completing 2 turns directly over one another, just like at the beginning, without moving the position of the bandage. Step 5. Use the binding clips found in the bandage packaging or apply a strip of adhesive tape to keep the bandage in place. Avoid anything that might increase swelling in the first 48 hours after an injury, like a hot shower or drinking alcohol. Step 6. Check for circulation by squeezing the tip of one of the fingers on the injured arm and see how long it takes for color to come back to the fingertip. If it takes longer than 3 seconds, unravel the bandage and redo it a little looser this time. Did you know? The funny bone is not a bone at all, but a nerve that runs along the ulna, one of the 2 major bones in the forearm.
Hi, I'm Carol James. I'm the Wound Ostomy Continence Nurse from MedStar Health Visiting Nurse Association. Today I am here with Mrs. Frances Steele, and I will be demonstrating how to change a wound dressing. The first thing you might want to do is wash your hands with soap and water, or if you prefer, you may use hand sanitizer. And actually, I'm going to use the hand sanitizer, and I'm going to have you do it also. We're going to put out all of our supplies so that you don't have to be going back and forth to actually get the supplies that you need. I'm going to elevate your leg. Take your finger and gently pull up the edge of the tape and push and pull. You want to discard your soil dressing. Take off your gloves. Use your hand sanitizer for the second time. Rub your hands together and put on our second set of gloves. I'm going to take one piece of gauze, hold against your leg, squirt into the wound. You want to go around from the inner out, discard, take another gauze, squirt onto the wound, your saline, discard, and then you can take one more and wipe around the wound itself. Once you have cleaned your wound, you want to examine it because you want to look at it to see if there are any changes in your wound. Use my hand sanitizer again. Okay, once you're finished with that, this is your third set of gloves you're putting on. Take a 4x4, you moisten it with saline. You don't want it too sopping wet, and then you want to open it up so we can fluff it on the wound base itself. And when I say wound base, I mean the area where the tissue is. We don't want to put the dressing outside on the skin, but we want to put it within the wound base itself. So here is where we would apply this. Then we're going to take a piece from the package of the skin protectant, and we're going to apply this around the wound. Now you want to wait for that to dry before you apply your secondary dressing, which is your dressing covering. Then we'll apply our dressing. Tear this before you actually apply your tape to your dressing, or you can just do it after you have applied the secondary dressing. As our last step, we washed our hands either with soap and water or use the hand sanitizer. It's really easy to do. It's a simple dressing. Just take your time and just remember to clean your hands between each step.
For how-to videos on any topic, visit monkeyseed.com.
Okay, so you're at the point where you need to start an IV. If you aren't comfortable yet starting IVs, the most important thing to do is not to panic. If you're going to start an IV, you need to go in with a confident attitude, and this process will go a lot smoother. So you'll want to have all your supplies ready before jumping in. The supplies that you'll need are going to be gloves, a beveled needle with catheter, an IV start kit, which typically includes a Tegaderm patch, gauze, a skin prep cleaning agent, tape, and a tourniquet. You may also need a 10 milliliter saline flush, which can then be used to determine whether or not you're in the correct location and vein patency. You may also want to tear your tape into strips, so you'll be completely prepared for the end. To begin, you'll want to find a suitable vein. There are numerous veins that can be poked, but the most common veins will be on the upper extremity, mainly your antecubital fossa and the dorsum of the hand. There are a lot of different tricks that seasoned IV veterans use to make the veins bulge out, but a few of the more common ones are going to be asking the patient to clench and unclench their hand, 5 or 10 seconds. Another trick is going to be to have the patient hang their arm off down by their side for a few seconds to increase blood flow down to the hand. Some people prefer to tap a vein, which may help also reveal a good vein. So either of those techniques are what is commonly used out in practice. But don't be spending too long looking for a good site, since patients expect you to know what you're doing, even when you may not be a pro. So let's begin an IV start. To begin, you'll need to apply a tourniquet. There is no magic location on where to place the tourniquet, but as a rule of thumb, you want to apply it, about half an extremity proximal to the puncture location. So in this example, if you want to start an IV on the dorsum of the hand, then you'll want to tie off approximately at the middle of the forearm. Since we're going to be doing the antecubital fossa, just halfway up the humerus is going to be fine. I'll demonstrate one version of the tie of how to do that. So for this, you'll want to make sure that the tourniquet can be removed by one hand only. So to tie it, you'll be taking both sides as demonstrated and then crossing over and then tie it off so that way the tourniquet can be removed by pulling just one side. There are great videos online, and we'll actually make a video later on how to do this. Our next step is going to be cleaning the site where you're going to be introducing the needle. This is to prevent any infection once you break the skin surface. So for our kit, we have a little prep kit. You'll just break the little tube inside and then prep this site where you're going to be injecting. So we have a vein found, and now you'll want to possibly anchor it. Veins do roll, so anchoring the vein will help you when inserting the needle. To do this, you'll want to grab with your non-dominant hand a few inches just distal to the vein, and with your thumb apply some traction to the skin. So you're dragging the skin away from that site. This helps reduce the number of rolled veins and will make you look like an IV pro. Now it's time to grab your needle and catheter. The most important thing is to remember bevel up. Now what do I mean by bevel up? Here we see a drawn in needle where we have the sharp pointy side at the bottom closest to the skin and a scoop or a hollow side up near the top. Bevel down just simply means you're putting that pointed needle side down as close to the skin as possible. Now what you'll do is you're going to be removing the tip, exposing the catheter and needle, and you'll want to figure out an angle to insert at. Typically, you don't want to insert the needle at a 45-degree angle because you're not digging for gold, you're digging for a vein. Veins run pretty superficial to the skin, so it won't take long before you encounter a vein. I typically hold the needle at about a 15-20-degree angle to the skin. Make sure you insert the needle in a nice and controlled fashion. Once you hit a vein, there will be a little flash chamber in the needle that will fill. And you can see that there is a little red in the flash chamber. This tells you that you have pierced the vein. If you're in the correct location, your next step is to advance the catheter from the needle. Make sure you don't move your needle hand, you're just moving the catheter. So don't move the needle, just move the catheter. This is the biggest tip. So we're simply sliding off that catheter from the tube, from the needle. Advance the catheter as far as it can go down into the vein and then remove the needle. Some needles, like this one, are spring-loaded and retract once the button is pressed. Now we need to be ready to stop the bleeding. As you can see, we apply pressure directly proximal to the site because this will prevent the backflow of blood through the hollow catheter. To slow this, you'll do two things. You can place pressure as shown and also remove the tourniquet. Next, what you'll want to do is you'll want to check the correct location of the catheter. So we're going to use a 10 milliliter saline flush. Now here, what we're doing is we're attaching the saline flush and checking the patency of the vein. If the saline easily moves into the skin, or into the vein, then we are in the correct location. If we see a wheal forming, which we do not, which would just be a tiny bubble underneath the skin, it would show us that our catheter tip is not in the correct location. But as you can see here, we have just injected 10 milliliters or 10 cc's of saline, and if it was not in the correct location, we would be able to tell. But however, it did go into the vein, so we are in the correct location. Now you can remove this and attach any further tubing as necessary, but for the sake of this video, we'll now show you how to remove a catheter. To remove the catheter, what you'll need to do is you'll need to get some gauze ready. We just have some 2x2 gauze pads. Now what you'll do is you'll apply some pressure just proximal to the catheter. Now you'll just remove the tubing by applying pressure with this thumb and removing the catheter slowly as shown. Now you can apply some pressure for about 5 to 10 seconds, apply a bandage, and then you are done. We'll tape it off just in the example shown, and that is how to start and remove an IV.
Medications that are irritating to subcutaneous tissue or medications that discolor the skin must be given using the Z-Track method. The Z-Track method is similar to the intramuscular injection procedure, except that the skin and subcutaneous tissue are pulled to the side before the needle is inserted. The Z-Track method causes a zigzag path through the tissues when the needle is removed and the skin is released. The zigzag path seals off the needle path and prevents the medication from reaching the subcutaneous layers or skin surface. The medical assistant will show you how to administer an iron dextran injection into the dorsogluteal site using the Z-Track method. Ask the patient to remove clothing as necessary to ensure the area is fully exposed. Divide the buttocks into quadrants. The site is located in the upper outer quadrant about 2 to 3 inches below the iliac crest. Prepare the injection site. Cleanse the area with an antiseptic wipe using a circular motion, starting at the injection site and moving outward. Do not touch the site after cleansing it. Allow the area to dry completely to reduce the irritation and patient discomfort that can be caused by the antiseptic entering the skin when pierced. Apply gloves and remove the needle guard. With the non-dominant hand, pull the skin away laterally from the injection site approximately 1 to 1 1/2 inches. Insert the needle quickly and smoothly at a 90-degree angle. Aspirate to determine whether the needle is in a blood vessel. If blood appears, withdraw the needle, throw away the syringe, and prepare another injection. Inject the medication slowly and steadily. After injecting the medication, wait 10 seconds before withdrawing the needle to allow for initial absorption of the medication. Withdraw the needle quickly, keeping it at the same angle for insertion. Release the traction on the skin to seal off the needle track. This prevents the medication from reaching the subcutaneous tissue and skin surface. Do not apply pressure to the site because it could cause the medication to seep out. If you are using a safety syringe, activate the safety feature at this time. Properly dispose of the needle and syringe in a biohazard sharps container. Remove your gloves and sanitize your hands. Chart the procedure. Include the date and time, the name of the medication, the lot number if required, the dosage given, the route of administration, the injection site used, and any significant observations or patient reactions.
This vein is coming into clear view. I have my target right there. Okay? So the next thing I'm going to do is we're going to alcohol this off. We see our target. Next thing is lidocaine. Okay? This is just a 30 gauge needle. If you're good at this, you won't even feel it. Okay? The effective way to use lidocaine is just to go right underneath the skin. You see how that little skin wheel is popping up there? That's effective lidocaine. Did that burn?
No.
So you didn't even feel it because we just went right underneath the skin, okay? So I'm going to hold traction in that direction, gets my thumb out of the way, and I'm going to hold counter traction in that direction, okay? I see where my vein is. Next thing I'm going to do is I'm going to go in 100% parallel. So I'm going to go in here until I get a flash. Here's my flash of blood. I'm going to advance this just a little bit. Okay, that is in. Now from here, we need to take the tourniquet off. Gauze has to go under here next, and then the needle can come out. So I better see that every time the angiocath goes in, take the tourniquet off, then hold digital pressure and put gauze underneath here so you don't bleed all over the patient. And then, last step, we hook up. Look, and now I was able to get that IV in without bleeding everywhere. And then we just secure this sucker into place, okay, with a tegaderm. And then we can get another piece of tape here to secure this even better. All right, let's see the student's demonstration. I'm going to do a nice tight tourniquet there. See how many arm hairs we can pull out while we're doing it? Okay. So just underneath. Now keep going till you see a skin wheel.
How big do I want?
That's great. Okay, more parallel. There you go. Now keep going. Advance parallel. More parallel. Keep going. Now advance a whole thing. No, not the angiocat, the whole thing. Okay, now advance. Okay, now go ahead and pull the tourniquet off. Tourniquet off. Okay, now gauze. Yes. Actually, real quick, pull that off. Just let go of the traction. Oh yeah. No, okay, not too much. I just wanted to see if we were in. All right, awesome. Okay, real quick, watch my hands. This is how you hold lidocaine. Hold it like this, okay? And make sure when you go underneath the skin that it's parallel and it's bevel up, all right? Just underneath the skin, perfect. Get your nice skin wheel.
So about like that?
Yep. Now just advance parallel. You look pretty parallel to me. Go until you get a flash. You got a flash. Now advance a little bit. No. Advance the whole thing. Now, okay, stop.
Okay.
Now just advance the angiocath. Pull the needle back. Okay, now advance it with, yep. Perfect. Take the tourniquet off, okay? Underneath. Now retract your needle. Okay, see, look how your digital pressure sucks? Mm-hmm. You're grateful for gauze today,
Yes,
aren't
I
you?
am.
And we followed these successful principles, and look, we got an IV on our first time. Now here's my lidocaine. Just underneath the skin. Nice little skin wheel there, okay? I'm just going to do an IV. So good traction in both directions. My needle is 100% parallel. So I'm just going to go in. I've now hit his vein. And I've advanced the needle. So there's my angiocat. So gauze is under there just in case the digital traction isn't as effective. Now I can hook up my saline lock, okay? Now I can put my Tegaderm on.
Figure of 8 bandage for the knee. Commencing just below the patella, the bandage is carried firstly laterally, behind the ham to the medial side. It is continued over the tail of the bandage to the outer side of the knee and ascends across the back of the knee to reach the medial side of the knee, just above the joint. After going round the thigh, it descends as shown to encircle the leg. Thus, it forms a figure of 8, making one loop on the leg and one on the thigh. These loops are repeated until the bandage is complete. The movement of the knee joint is greatly restricted with this type of bandaging. Bandage for the leg. 1 or 2 figure of 8 turns round the ankle are taken to fix the bandage. A few spiral turns round the lower part of the leg are taken. The bandage is carried on to the knee by the reverse spiral method.
Повязка на один глаз называется монокулярной. Эта повязка выполняется чередованием двух туров. Первый круговой ход делается вокруг лба и затылка. Затем бинт спускается от затылочной области косо вниз под мочку уха. Второй тур идет косо вверх на правый глаз и удерживает салфетку.
Administering nebulized medication. For this procedure, you will need the medication record, a nebulizer set and the medication, or a prepackaged nebulized medication and applicator, saline, an air compressor or wall air or wall oxygen, a metered dose inhaler, and an aero chamber if appropriate. You may also need a cup, an emesis basin, tissues, some warm water or saline to rinse the mouth after treatment, exam gloves, and goggles and mask if the client is coughing or sneezing. Gather the necessary equipment. Select the ordered respiratory drug. Check the liquid respiratory medication for discoloration and check the expiration date on medications. Check the respiratory medication against the client's medication record and calculate the drug dosage if needed. Check to see if the respiratory medication is pre-mixed in saline or if you will need to add a prescribed amount of saline to the nebulizer. Check to make sure you have the 5 rights: right client, right medication, right dose, right route, and right time. Check the client's chart for drug allergies and hypersensitivity. Proceed to the client's room and provide for privacy. Verify the client's identity, then explain the therapeutic purpose of the medication. Position the client in an upright position for better expansion of the lungs. Assess the client as appropriate. Wash your hands before setting up the nebulizer. Verify the medication the 3rd time and then prepare it for administration. Attach the tubing to the bottom of the nebulizer cup and attach the other end to the air compressor or wall air. Look at the medication at eye level if using a dropper to dispense the solution into the nebulizer. Determine the correct amount of medicine and pour the entire amount into the nebulizer cup carefully so you avoid touching the drug. To prevent spillage, cover the cup with the cap and fasten it. Fasten the T-piece to the top of the cap. Always avoid touching the nebulizer mouthpiece or the interior part of the mask. Before turning it on, adjust to 6 liters per minute or less per the physician's orders. This drives the medication into a mist or wet aerosol form. Administer the entire dose of medication. This usually takes about 10 minutes. The medication is completely administered when there is no more mist being produced. Instruct the client to breathe in and out slowly and deeply through the mouthpiece or mask. The client's lips should be sealed tightly around the mouthpiece. Remain with the client long enough to observe the proper inhalation-exhalation technique. Also, observe the client for any side effects or distress while the medication is being administered. When the nebulizer cup is empty, turn off the compressor or wall air to stop the aerosolization. Detach the tubing from the compressor and the nebulizer cup to prepare all the components for cleaning or disposal. If the nebulizer is disposable, dispose of it in the appropriate container. If the nebulizer will be reused for this client, follow your institution's policy regarding the cleaning and storage of the nebulizer components. Assess the client immediately following the treatment for results or adverse effects from the treatment. After the treatment, offer the client a mouth rinse with warm water or saline. Reassess the client 5 to 10 minutes following the treatment, as some effects may be delayed. Dispose of your gloves and mask, if used, and wash your hands. Record the medications administered on the medication record and record the assessment data. Metered dose inhalers.
When using metered dose inhalers, provide for privacy and verify the client's identity. Explain the purpose of the medication. Then wash your hands and don gloves before administering the medication. Verify the medication against the client's medication record. Place the inhaler into the applicator and then place the aero chamber onto the inhaler if it is needed. Shake the pre-packaged inhaler to thoroughly mix the medication before each inhalation of medication. For example, if the client is prescribed 3 puffs, you would shake the nebulizer 3 times. Instruct the client to exhale deeply before using the inhaler. Next, have the client place the mouthpiece in his or her mouth and close the lips tightly around the mouthpiece. Instruct the client to press down firmly and steadily on the metered canister to dispense the medication into the chamber while simultaneously breathing in slowly and deeply to inhale the medication. Have the client try to hold the breath for 10 seconds if able, then remove the inhaler to slowly exhale. If the client is supposed to take more than 1 puff of the inhaler, have the client wait at least 60 seconds between each prescribed puff of medication. After the treatment, offer the client a mouth rinse with warm water or saline. Observe the client for several minutes to assess for any possible adverse effects from the medication. Inhaler medication is delivered into the bloodstream almost immediately, and reactions can occur very quickly. Remove your gloves and wash your hands. Record the medication administration and your observations.
It is important that the Manitou TB skin test be done correctly and read accurately. It takes practice to be good at doing this. Your skill in administering the test, reading the results, and responding appropriately are important to the control of tuberculosis.
Prepare for the test by gathering the necessary supplies and equipment. Meet with the client to explain the test, obtain informed consent, and make certain there are no contraindications to giving the test. Answer any questions and ensure the client can return within 48 to 72 hours to have the skin test read. Begin with hand hygiene, then check tuberculin has been stored according to guidelines and has not expired. Draw up exactly 0.1 milliliters of tuberculin. Clean the injection site with an alcohol swab and let dry. With the bevel of the needle facing up, insert the needle at a 15-degree angle just below the surface of the skin. You will feel some resistance as the tuberculin is injected. Placed correctly, the injection will produce a wheal 6 to 10 millimeters in diameter. If a wheal this size does not appear, the test must be repeated 5 to 10 centimeters from the first site or on the opposite arm. Dispose of the needle in a biohazard container. Gently dab any blood with a cotton ball, do not press on the wheal, and do not cover the site with a Band-Aid. Remove gloves. Perform hand hygiene and complete required documentation. Observe the client for 15 minutes for possible allergic reaction. Read the TB skin test 48 to 72 hours after tuberculin is administered. Begin with hand hygiene. Under good lighting, examine the client's arm. Lightly palpate the site to feel for a hard, raised, and dense area of swelling or induration. If no induration, document as 0 millimeters. If induration is found, locate the edges of the induration on the transverse axis of the arm, the same direction as the watch band. Use a ballpoint pen held to a 45-degree angle to mark the outer edges of the induration. The pen will stop at the edge of the induration. Use a caliper ruler to measure the diameter of the induration. Document in millimeters of induration. Redness can occur with or without induration and is not included in the measurement. Document any blistering with or without induration. This may indicate an allergic sensitivity. Caution is advised regarding subsequent testing. Complete documentation of the skin test result. Provide a record for the client. If appropriate, advise client of any next steps. This chart helps to determine a positive result and therefore reportable to public health. Staff will consult with you regarding the significance of the reading. Induration of 0 to 4 millimeters is considered positive if the client has HIV infection with immune suppression and the likelihood of TB infection is high. For example, the client is from a population with a high prevalence of TB infection, is a close contact of an active contagious case, or has an abnormal chest X-ray. Induration of 5 to 9 millimeters is considered positive if the client has HIV infection, is a close contact of an active contagious case, is a child suspected of having tuberculosis disease, has an abnormal chest X-ray with fibronodular disease, or has immune suppression as a result of TNF-alpha inhibitors or chemotherapy. Induration of 10 millimeters or more is considered positive in all other situations. Let's review. Prepare by gathering necessary supplies, getting informed consent, and making sure the client can return within 48 to 72 hours. To give the test, first wash your hands and don gloves. Be sure the tuberculin has not expired, clean the injection site with alcohol, and inject just below the surface of the skin, checking for a wheal of 6 to 10 millimeters. Read the test by checking the arm for induration. No induration is recorded as 0 millimeters. If there is induration, mark edges with a ballpoint pen, then measure diameter with a caliper ruler. If the result is positive, report promptly to the public health unit. In some circumstances, a second TB skin test is done 1 to 4 weeks after an initial negative result. This should be done for persons who may require subsequent testing, such as healthcare and correctional workers at time of hire, people who are new residents of a long-term care facility or retirement home, or for people who are traveling to a TB endemic country for a prolonged period of time.
It is important that the Mantoux TB skin test be done correctly and read accurately. It takes practice to be good at doing this. Your skill in administering the test, reading the results, and responding appropriately are important to the control of tuberculosis.
Bandage for the thumb. A spica bandage is suitable especially when pressure is required. With a bandage 1 inch wide, fix it round the wrist by taking 2 turns from within outwards. It is then carried distally to the tip of the thumb, round which a loop is formed. The bandage next travels over the back of the hand and forms a loop round the wrist. Thus, a series of figure of 8 turns is taken alternately round the thumb and the wrist. The bandage is completed by taking 2 turns round the wrist.
This program will present techniques for the administration of topical medications, suppositories, and inhalants. Not only do patients depend on nurses to administer medications competently and effectively, they also depend on nurses to administer medications safely. The nurse is the last line of defense to protect a patient against a medication error due to the wrong drugs, the wrong dosages, the wrong times, the wrong routes of administration, or the wrong documentation. Topical medications, including creams, foams, ointments, solutions, and lotions, are directly applied to the skin or mucous membranes. Topical medication may be prescribed to bring about a therapeutic local response, but often topical medication is prescribed for its systemic response by absorption through the percutaneous tissues. A local effect, such as cessation of itching or decreasing an inflammatory condition, are examples of a topical substance prescribed for its local effect. Drugs such as analgesics, hormones, and vasodilators are examples of topical medications used to bring about systemic effects. These latter examples are usually applied in the form of transdermal discs or patches. Before administering any topical medication, the nurse should don protective gloves. This practice ensures that the nurse's skin does not come in direct contact with the medication, thus avoiding a possibly unwelcome dose of the medication. Lotions may be protective, drying, or soothing, or may be prescribed to relieve itching and are often used to treat skin lesions. Lotions are not routinely washed off between applications. A cream is an emulsion of oil and water in a semi-solid form. It lubricates the skin and retards loss of moisture. Creams are applied easily and usually are cosmetically acceptable to the patient. An ointment is a greasy, semi-solid suspension of oil and water, commonly referred to as a salve or an unguent. An ointment retards water loss and protects the skin. Ointments are used to treat chronic and localized skin lesions. A paste is a semi-solid preparation, thicker and stiffer than ointment, that causes it to be absorbed through the skin more slowly than an ointment. A paste also repels external moisture.
Okay, so the doctor prescribes some medication to take care of your arm. Can I see that? Okay, I'll clean it up and I'll put some medication on it. Okay?
Provide patient privacy, perform hand hygiene, and don gloves. Before applying a topical medication, the nurse carefully assesses the area. The skin surface is gently cleansed using an applicator or sterile gauze pad. The medication is applied sparingly to the affected area only. After any topical treatment has been applied, the nurse should assess the patient frequently for any adverse reactions, such as redness, swelling, or
In this chapter, we will be learning about administering an injection in the vastus lateralis site. Where a drug license allows, the patient may choose this site. The vastus lateralis site targets the lateral side of the quadriceps femoris group of muscles and is situated in the anterior lateral aspect of the thigh. The patient should be asked to adopt either a sitting or lying position with their upper leg exposed. It is located by placing the little finger of one hand on the lateral femoral condyle of the knee and the little finger of the other hand on the greater trochanter. Now try to touch both thumbs together. Both hands are then spanning the distance and the injection site is at the midpoint. Once you are confident you have accurately located the injection site, remove your hands to prevent needle stick injury. Clean the skin if necessary with soap and water or according to local policy. Administer the injection using the Z-track technique. Dispose of all equipment immediately and safely into an appropriate puncture-proof, correctly labelled sharp spin. Do not resheath the needle. Remove gloves and wash your hands according to accepted hand cleansing technique. Record on the prescription or administration chart the date, time and dose of medication administered, which site and which side of the body was used. Ensure any deviation from standard practice is recorded along with the rationale for doing so. Change information about monitoring arrangements and ensure the patient is aware of how they might manage common side effects. Make sure the patient knows who to contact if they are concerned about changes to their physical and mental health before they are due to be seen again.
Повязка ДЗО выполняется с целью иммобилизации плечевого пояса при переломе ключицы. В подмышечную область обязательно вкладывается ватно-марлевая подушечка. Повязка начинается от здоровой стороны, плечо фиксируется к туловищу. Продемонстрировано наложение 4 основных ходов бинта при выполнении этой повязки. Для надежной фиксации 4 хода повторяются в дальнейшем 4 раза. Повязка на грудную клетку. Для выполнения этой повязки на правое надплечье кладется марлевая лента длиной около 120 см. Начинают бинтовать от нижнего края реберной дуги спиральными турами вокруг грудной клетки. Каждый последующий тур наполовину прикрывает предыдущий. Заканчивается повязка на уровне подмышечной области. Затем концы марлевой ленты поднимают и завязывают на левом надплечье. Существует несколько способов закрепления перевязочного материала на животе. В данном случае демонстрируется техника выполнения повязки, с помощью которой закрывают правую подвздошно-паховую область. Циркулярный тур вокруг туловища бинтуется справа налево. Каждый оборот вокруг живота чередуется с 8-образными перекрестами вокруг бедра. Заканчивается повязка циркулярным туром на бедре. Повязка на коленный сустав. Повязка черепашья, расходящаяся на коленный сустав, начинается с области коленной чашечки одним круговым туром. В области подколенной ямки бинт перекрещивается, уходя поочередно вниз и вверх от середины коленного сустава.